Suicide is an act of desperation. Most individuals do not want to die. They just don't know how to go on living with their psyche or physical pain. Suicide is a global problem, and according to the World Health Organization, or WHO, in the last 45 years, suicide rates have increased by 60% worldwide. WHO also found that suicidal thoughts, plans, and attempts appear to be similar across the globe. In the U.S., there are presently only 4 states that have legalized physician-assisted suicide. Oregon was the first to pass the Death with Dignity law, then Washington State, Vermont, and then most recently California. There are a couple of states that have bills pending legislation. Montana, however, has a death by physician assist law, but it is determined by court hearing only. The issue of the right to die with dignity is vastly controversial and complex. Washington State passed the PAS law in 2009. They state that the following conditions must exist for a patient to qualify for an assisted suicide. 1. The patient must not have any neuromedical or psychiatric conditions that impair the capacity to reason and process information. 2. The patient must be diagnosed as having less than 6 months to live. 3. The patient must make a request orally and in writing, then have the agreement for the PAS approved by 2 different physicians that agree the patient meets criteria. And lastly, after a 15-day waiting period, the patient must then make the request again. This gives the patient a way to opt out after making this decision. Sigmund Freud developed some of the first psychological theories of suicide in the 1900s. Freud described suicide as a murderous attack on an ambivalently loved, internalized, significant person, often referred to as murder in the 180th degree. Building on Freud's theory, Karl Menninger suggested that all suicides experience 3 interrelated emotions: revenge, depression, and guilt. Edwin Schneidman proposed that victims of suicide suffer unbearable psychological pain, a sense of isolation, and the perception that the death is the only solution to their situation. In essence, an individual feels that there is no other way out. Schneidman identified self-destructive behaviors such as compulsive use of drugs, hyperobesity, gambling, harmful sexual behaviors, and medical noncompliance as sub-intention suicide. Herbert Hendon, medical director of the American Foundation of Suicide Prevention, states that Schneidman was the first person in the United States to call public attention to the problem of suicide. Hendon goes on to say that, however, the biggest advances in the field of suicide prevention in the last 15 years have been in the field of biology and the pharmacology of depression and suicide. It borders on the malpractice for a doctor not to prescribe medication for a seriously depressed individual. Scientists have identified a strong association between suicide and the molecular genetics of the neurotransmitter serotonin. For example, people who attempted suicide have lower serotonin functioning. However, those who have completed suicide have the lowest levels. Studies of the brain of those who have committed suicide show abnormalities of the serotonin system in parts of the prefrontal cortex in an area of the brain called the ventral medial prefrontal cortex. Low levels of serotonin in cerebrospinal fluid have long been associated with impulsive suicide-like violence. Low levels of serotonin are known to be significant factors in people who develop depression. The noradrenergic system is a mediator of acute stress responses, and overactivity of that system has been associated with both severe anxiety or agitation and higher suicidal risks, according to Mann's research at the literature. The hypothalamic pituitary adrenal axis is another major stress response system. The HPA axis is associated with major depression in suicide victims that are often exhibiting the HPA axis abnormalities. Suicide has long been shown to cluster in some families. Therefore, family history is pertinent for the nurse to obtain. Societal factors that may increase the potential for suicide include loss or lack of social supports, negative life events, and severe life stress. Therefore, suicide potential is apt to be higher among individuals facing these circumstances, including those who are impoverished, recently divorced, separated, or bereaved, are childless or homeless, live alone, have few to no support systems, and are grappling with recent negative life events. Suicide also seems to be higher among the unemployed. Suicide risk factors must be documented and reported by the nurse. Some of the most prominent include presence of a plan, previous suicide attempt, history of mental disorder, particularly depression or alcohol, drug abuse, impulsive or aggressive tendencies, adverse life events, recent or unexpected loss, feelings of hopelessness or isolation, family history of mental or substance abuse disorder, family history of suicide or prior suicide attempts, family violence including physical or sexual abuse, incarceration, exposure to suicidal behavior of others including family, peers, or newsworthy persons, even fiction, and lastly, chronic physical illness, particularly if associated with chronic pain. Often these signs are huge warning lights for suicide, but it is important for us to watch for silent signs as well. Some of these include a flat affect of the face, giving away possessions, and often you'll see a sense of calm from a person who has been ravished emotionally and mentally. It seems as though they are realizing that they are finally going to have some peace in this world that's been a storm for them for so long. Giving away prized possessions may signal that the individual will no longer need these items and that a suicide plan is already in place. The farewell notes may be a cry for help, or a person who does not want to say goodbye to loved ones in person.